Hello and welcome again to A&T Neuro Educational Webinar Series. My name is Farnoosh Safavi. I'm the Head of Education Department, and it's my absolute pleasure today to be moderating the webinar on the opportunities of dry EEG in the investigation of disorders of consciousness. This insightful webinar will be presented by Dr. Robert Fleischmann, who is a consultant neurologist at the University Hospital Greifswald in Germany. He specialized in neurological intensive care at the Charité Berlin until he moved to Greifswald to lead the movement disorder section and co-lead the Delirium prevention unit, providing consultation services for in-hospital patients at risk for neurocognitive complications. Since his first days in intensive care, he pursues a strong interest in neurophysiological research of delirium to better understand its underlying brain states and to improve the clinical management side. His special interest is the investigation of QEEG that provides surrogate readouts of a network dysfunction and thus potential biomarkers of delirium endotypes. After this interesting presentation, we will have a short demo video prepared by Dr. Fabio Barolo, our senior application specialist at A&T Neuro and PhD in biomedical engineering as background. In the course of the presentation, as some of you might know, you have the option to type your questions, which will be addressed at the end of the session as far as the time allows. Also, like most of our other webinars, you will be exposed to some poll questions where we will appreciate your active participation. So, Robert, once again, I would like to thank you for accepting our invitation and being with us here today. Without further ado, we are all ears to hear about your interesting research. Thank you.
Yeah, so thank you very much for having me, for the invitation. I'm very happy to talk about this topic, which is really I have a strong interest in delirium since my early residency, when I first encountered this kind of disorder and really was frustrated dealing with the patients, and was kind of interesting to see that there's no biomarkers for this quite frequent disease. So I thought there must be something to do about it to get a better insight into the disorder. And this is when I started the EEG research, or neurophysiological research, basically. Yeah, you already introduced myself, so just for those who don't know where Greifswald is, which is probably everyone because it's a small town at the Baltic Sea. It's a nice little university hospital, and we have about 800 inpatients, and the delirium prevention unit actually deals with all disciplines. Like we work in general surgery, neurology, internal medicine. So we see delirium in almost all settings in hospitals, including intensive care. And this is also some of the data you're going to see is from these patients. So I'm a neurologist, so I basically mostly work in clinics and do some research that's accompanying my clinical work. And I would be interested to hear about your background. So this is where the first poll would be started, and I would like to see where are you working, if you're more doing basic research or if you're also working in clinics.
So the poll is ongoing,
Mm-hmm.
and let's see what the background of the audience is. All right, 80% have already voted. We can close the poll and share the results. 27% PhD students, 9% medical doctor or researcher, 64% other.
Okay.
Let's go to the next question. Yeah.
Okay, that's interesting. Next question would be, what is your EEG experience, so that I can kind of know how much I have to go into detail.
All right, let's give it 30 seconds or so. I think we can close the poll and share the results. As multiple answers are allowed, that's a bit different. So can you actually see the results, Robert?
I can see the results, yeah.
Okay, would you like me to read them out for you, or you'd
No,
like
I can
to
see them.
give an
Fine.
overview? Okay.
Yeah. Okay, and the final question. So most of the people are used to doing routine 1020 EEG gel-based, saline-soaked, 40%,
Exactly.
and dry EEG at least 20%. So 20% already know dry EEG. That's very interesting. And finally, what is your research area of interest? Like, is it also delirium, other disorders of consciousness?
Time to close the poll. And let's see the results.
Okay.
So 55% other, 27% anesthesia, 36% encephalopathy, 18% unresponsive wakefulness or similar disorders, and 9% delirium. So it will be actually interesting to expand their knowledge on delirium today.
Yeah. So delirium is really something that might be new to some of you, although the broader concept of disorders of consciousness is applies to various of the disorders. So I'm going to show some. I'm going to put delirium into context of the other disorders during the talk. I thought it would first be good to talk about why EEG would actually be a good measure or a good readout, would provide a readout for delirium, which is not kind of a straightforward thing, because delirium is some psychiatric disorder, let's say neuropsychiatric disorder. So why would EEG be a good readout of that, and what does it tell us about what's going on in the brain? So what's the potential source of the EEG changes? Then I would introduce the qualitative and quantitative EEG changes that are kind of known to be seen in delirium, and also put delirium and encephalopathy into context. And finally, since the title of the talk is Opportunities of Dry EEG, give you an idea why I think dry EEG is a good technology, or a really good opportunity to investigate disorders of consciousness, and what the benefits might be using that instead of gel-based EEG. So why would EEG be a good proxy measure? And when I first not go into delirium, but go into acute encephalopathy, something you might have experienced yourself. Let's see this mouse. This mouse has been injected with either a control substance or lipopolysaccharide into the belly. LPS would induce a severe inflammatory response in the mouse. And what you see is that the walking distance of the mouse after the injection suddenly decreases. So you have something injected into the belly, which is a kind of remote area from the brain, obviously, that then ultimately affects the behavior of the mouse. So there has to be some link between the periphery and the central nervous system. And what we see is it's not only affecting locomotion, but also nest building scores, water consumption, food consumption, something we as a neurologist would call ankylopathy. So something you might experience when you have a severe flu. You want to lie in bed, you don't want to eat much, you don't want to drink much, you just want to basically sleep and not move too much. So this is what we call encephalopathy, or behavior associated with acute encephalopathy. And encephalopathy is actually something that it has a definition, and the definition is that it reflects the pathobiological process in the brain. So it does not actually relate to the behavior we see on the outside or the phenotype, but it's more the biological process underlying the behavior. And the behavioral response that we see in a patient, I think there's no delirium in mice, not in the terminology we use it in humans. So what we see in patients is something we would call delirium. So that's the behavior associated with encephalopathy. And subsyndromal delirium would be a patient who has some features of delirium. Full delirium would be a patient who has all features of delirium required by DSM-5, which is the classification system. And if you have very severe encephalopathy, you can't even say the patient is delirious because he or she is comatose. And in coma, you can't obviously assess the patient's cognition. So that's basically coma, but it's the worst phenotype associated with acute encephalopathy. So just to say, we really have to distinguish between the phenotype we are observing in a patient and the endotype, which is what is going on in the brain. And obviously, there seems to be some continuum or some spectrum in the phenotype. Talking about delirium, you can kind of distinguish that by motor types. So you can say there's hyperactive delirium. These are the patients that are restless, agitated, hypervigilant, don't follow your instructions. So you tell the patient not to stand up and he or she is walking around. The hypoactive patient, this is the patient who's just lying in bed, not paying attention to you entering the room, sleeping much, not eating, not drinking. And then you can also distinguish delirium by setting. So this means that you can have a delirium following surgery, you can have delirium following stroke, in palliative care, intensive care. That's actually interesting because the predisposing mechanisms leading to delirium may be different in a patient who suffered acute stroke than a patient who just underwent surgery or who has severe sepsis in ICU. So it's not necessarily all the same triggering event or predisposing or precipitating factor in all settings. So that's why you always have to know where's the patient actually treated, or where was that study done, or this or that study done. Irrespective of setting and motor type, you have some broad criteria that define the phenotype. That's actually the interesting thing we're going to see later, is that all we can do is actually diagnose a patient by the phenotype, because the acute encephalopathy is something we cannot assess by now. The clinical criteria for the phenotype would be you have a acute change of the patient's cognitive state or consciousness. That means if the patient was normal the day before surgery, then underwent surgery, and all of a sudden is inattentive and sleepy, drowsy, you would say that's definitely an acute change from the baseline condition. You then have to have a disturbance in attention and a disturbance of awareness, both of which basically mean you have a disorder of consciousness, especially the awareness. So you're not consciously aware of your place or the situation or what's going on around you, or maybe even who you are. And then you must have some sort of additional disturbance, neurocognitive disorder, memory, language, perception, any of that. And if you have all of that, that would qualify for delirium. If you have just some of the features, that would be a subsyndromal delirium. And what you need is you have to have some evidence, of course, that there's a medical condition that caused the acute change. So that it's not a language deficit due to stroke, for instance, that it doesn't go with a disorder of awareness or attention, or that you have some patient who has dementia, progressive aphasia, and that's why the language is disturbed. So that's clearly not delirium, that's dementia. So you need some acute medical event that causes a disturbance of attention, awareness, and another cognitive domain. So when you want to put delirium into context of other disorders of consciousness, you might want to put it somewhere around here. This is something I just put into that chart from the publication. So delirium is something that has certainly decreased awareness. So it has to be somewhere in the middle. If it's very low awareness, like coma, you can't call it delirium. So it's somewhere in the middle. And then when you're talking about arousal, delirium wouldn't be like when you have a normal arousal, when you're not either agitated or drowsy, you wouldn't be able to call the condition delirium. So delirium has to have some sort of change of quantitative level of wakefulness, let's say. So you have either to be too much agitated or too low arousal, like drowsy. Okay, and like all of these disorders have one thing in common, and this is that they are all classified by their phenotype. So you would say like in delirium, there was nothing that says you have to have a brain scan, MRI that has to have these or that features, or you have no EEG classification. There's no blood biomarker. So all we do is we say this patient has a acute change in attention, awareness, and let's say language, and then it's delirium. But we actually do not talk about the brain itself. Like there would be if you say the patient has a low blood pressure without actually thinking about measuring ejection fraction of the heart or anything like that, or looking for a heart attack during troponin exam. So basically, we just say, okay, this patient has chest pain, and that's it. But I think we have to go further. We have to examine the brain because it's a disorder of the brain. It's an acute encephalopathy, underlying delirium, and we have to investigate the brain. Because for now, we kind of, like in every study, deal with the condition as if the phenotype, that is delirium, would be equivalent to the endotype. So we have a patient with delirium, and every patient with delirium should be somewhat the same when we're talking about the disorder of the brain. So if that was true, we wouldn't have a major problem because that's kind of equivalent. But what we know from all the studies done in delirium, that it's not that simple. So we see that we have in clinical routine and research, we don't have standardized approaches. We don't have any guideline that tells us in this patient we have to do this, and in the other patient another approach would be more useful because it's better linked to the pathology. We actually deal them all the same or treat them all the same, but it might also be that what we're seeing on the outside is just part of what's going on in the brain. So the endotype is more than we see, that maybe even the control group may have some sort of delirium. So the study is futile because the patients we selected are not all the patients we should have treated. And what's also possible is that all the patients we see as a phenotype are actually not all the same when we're talking about the encephalopathy. So there might be different mechanisms going on. So the endotype might be different, but on the outside they might appear to be the same. So this is really a huge problem, a huge dilemma. And like in this mouse, we wouldn't be able to to see if the mouse suffers from LPS induced acute encephalopathy. It's just we would see it walks less than the other mouse, so it suffers kind of hypoactive delirium. But then in the same study, what they did is they did an investigation of neurophysiology, kind of EEG in the mouse. And what you see is after LPS injection on the top left, you see there's an increase in slow wave activity 2 to 8 hertz, and this kind of is reflected in when you look at the spectral entropy in a decrease of entropy. So there's less communication and more slow wave activity, which may be inhibitory. And this is kind of the idea behind the assumption that EEG would reflect the brain state, or the, let's say, might also be a different mode in the brain associated with acute encephalopathy. So that kind of the substrate of delirium becomes measurable by EEG. And actually what we know is that the peripheral inflammation, which is nicely shown in this illustration, like on the left side, you have the periphery, you have the systemic inflammation, you have the cytokines, interleukins, TNF, and so forth, that cross maybe the blood-brain barrier or not. There's a kind of a point of discussion, but through some mechanism, it does activate the microglia, which is a resident immune cell in the brain, which then again does secrete some inflammatory cytokines and reactive oxygen species, and then in the end will affect the neuronal communication and also the astrocytes supporting the function of the neurons. So in the end, we have a link between peripheral inflammation and neuronal function. And this is kind of what we see in the EEG. And it's not only microglia, it's also astrocytes. There is some sort of vascular dysfunction, which will also affect neuronal communication. And in the end, all the mechanisms go down to, will ultimately affect neuronal networks, which then causes phenotype of delirium. So this is, from my point of view, and it's not only my point of view, explains why EEG is really the method of choice if you want to see what actually changes in the brain, let's say the organ of interest that causes delirium. So if you want to treat delirium, you have to understand what the underlying mechanisms on network changes are. Because if you don't assess that, you will always have a heterogeneous population just defined by their phenotype. Like again, when you treat patients with chest pain, you will not only have patients with myocardial infarction. There will be other disorders, but you would all treat them like myocardial infarction if you don't look at the pathology underlying the chest pain, or in this case, delirium. So you have to assess the networks. So just looking at the phenotype will lead to misdiagnosis and unstandardized ineffective treatment. This is kind of the situation we have with delirium currently in most cases. And also what we know is that there are multiple events that can cause a neuroinflammatory response, and neurophysiology is really the method of choice to read out the effects of the systemic events on the brain network function. Let's see what the EEG looks like in a patient with delirium. This is not something very new. This is a publication from 1944. So already by then, we knew that this is a patient with normal mental status. You have a frequency about 9 to 10 hertz, like a center frequency. And then you have a patient with mild delirium. And what we see is that the frequency decreases. So we have more 8 hertz frequency in this patient, and then it becomes even slower in more severe cases of delirium. This is what they call stupor. And you see marked delta wave activity in this patient with severe delirium. So that's not something very new, but I think what we now understand is why the EEG changes, or what are the mechanisms causing these EEG changes in these patients. And what they also saw in this study is this is a patient with anemia who was then treated with, so you have this 7 to 6 hertz EEG, and he was then treated with blood transfusion, and after the blood transfusion, EEG frequency increases. So already by then you knew there's a direct effect of the systemic events on the brain activity, which infers some kind of causation. So it's directly linked. And this is actually also something you can see in clinical practice. You often see the patient deteriorates, like a patient was awake the day before, perfectly conscious, and the next day he or she becomes drowsy. And then the next day you see the fever and the pneumonia. So you may even see the encephalopathy and the behavior, like the brain is a detector for cytokines in the system that may be seen even before you see them in the blood or before you can measure them in the lab. What is also interesting is that these EEG changes are not only a binary response, but you have on top the 3D CAM-S, which is a measure of delirium severity. And then in the lower rows, you see the EEG changes and the probability of EEG changes. And the more severe the delirium is, the more severe the EEG changes are. So that is also infers some direct relationship between EEG changes and what is going on in the brain. It can also be useful to differentiate between dementia and delirium, which is clinically challenging, as I said before, unless you know the state of the patient like months ago, which is not easy because you obviously know the patient since admission and not how the patient was in his home. This is another nice study that shows that the EEG changes may even precede the clinical phenotype. So you have a EEG score, like the changes in the EEG related to delirium are rated from 1 to 5, and depending on the amount of slow wave delta activity. And a score of 1 would indicate no encephalopathy, and a score of 5 would be severe encephalopathy. And what you see in a score of 3, you see 70% of patients have encephalopathy in the EEG, but only 20% of them are clinically delirious. When you go to score 5, it's 80% to 50%, and that score, at the highest score, you see that all the patients have some indication of encephalopathy, but only 70% of them are clinically delirious. So it's not that EEG is just a method to detect delirium in patients who are clinically delirious. It actually may detect cases that are clinically undetectable. So kind of the encephalopathy can be detected by EEG, the phenotype can be missed. So if you want to treat all the patients or want to include every patient eligible for a treatment, you should actually use the EEG and not the phenotype, which is currently not done. But from my point of view, is really something that should be discussed, that EEG should be an adjunct tool in clinical studies. So quantitative EEG changes is something, I think this study nicely, or this image from one study nicely shows the idea behind quantitative EEG. So in the top row, you have a patient with delirium and a control patient. And what you see is that the kind of power of the frequencies of the oscillatory activity at certain frequencies. And you see in the control patient, which is figure C, you see that there's a nice alpha band activity. So you have a higher power in the alpha spectrum. And in the delirious patient, you see there's marked slow wave activity, and alpha activity is pretty low, actually. And these are different patients, obviously. But in the bottom row, you see that you have the same patient who was delirious, which is figure E, who has then become non-delirious. So over time, he or she improves. And then you see that the slow wave activity power decreases and the alpha activity increases. So you see, it's not only something to distinguish delirious patients from non-delirious patients, but you can actually also monitor a patient with delirium if the patient improves due to a treatment, something that is not that easy when you just look at the phenotype. You might miss slight changes that are easily quantifiable using a quantitative EEG. And these changes in EEG, in particular the slow wave activity, are again closely related, in animal studies at least, to the systemic inflammation. And this is a study I did a couple of years ago, and this is the sensitivity and specificity for diagnosing delirium in a patient just based on quantitative EEG, not having any clinical information about the patient. And what you see, this is really something that you see in almost all patients. So you have a sensitivity of about 90%, specificity 90%. So that really works well. Like when you when you look at earlier studies doing qualitative EEGs, there are some studies that say there are patients with delirium, but they don't have encephalopathy, which means they don't have changes in brain activity. But I think this study clearly shows this is not the case. Like patients have encephalopathy when they have delirium. So this is interim summary would be clinical EEG is currently informative, but it's unstandardized and really depends on the patient reading the EEG. And quantitative EEG really has potential. It could assist the diagnosis, but criteria unclear. It has the potential to inform clinical management, like to monitor the disease activity or the severity of delirium, but relationship is unclear. And also, if you want to monitor delirium, which parameter would be best, like delta activity, alpha activity, also remains to unsolved. So we know there's potential, but as the Perioperative Brain Health Society from the American Society of Anesthesiologists concluded, we need more research. It should be, biomarkers need to be explored, and we need these proximal measures of CNS function. And obviously, EEG is really easy to obtain as compared to CSF biomarkers and functional neuroimaging. Like fMRI in a delirious patient is really not possible. EEG is possible. It's a bedside method. So what are the opportunities of dry EEG? So I think we have the idea about pathophysiology. We know what we need to measure. We know power is interesting. I will show one or two slides about connectivity measures. So we have some sort of idea what we need to measure in these patients. For now, we just treat all the patients the same. We say all these patients are delirious. They have these changes in alpha activity and delta activity and so forth. But I think the next step would be to see if these are really all the same patients. Are these homogeneous or are they not? And is it possible that these patients are maybe in different stages of the disease? It's not clear that delirium, first day delirium, or even subsyndromal delirium the day before overt delirium, they are mechanistically the same, or the same mechanisms are involved. So this is something we really need to look at. We need to see if there are different mechanisms going on in different patients, in different settings, hyperactive, hypoactive delirium. There are like so many differences in these patients that we really need to look at, but not from the phenotype, because the phenotype is delirium. But maybe the encephalopathy or the changes in EEG activity will tell us about different mechanisms and will allow us to have more tailored treatment approaches. And this was already done in something like the ECAM-S score that looked at different features to classify delirium, and they came up with a not too bad correlation between the confusion assessment method, which is a clinical tool, and the ECAM-S, which is the EEG variant. So it is possible with EEG to explain the clinical phenotype, but again, it's not necessarily valid to say that the phenotype really catches all the patients. So why possibly even the ECAM-S is more accurate than the CAM-S. But this is something that is unresolved and requires much more data. These are the features that were used for the machine learning tool. And these patients, or in this study, they used about 300 EEG features in 6-second epochs. So it's pretty low number for machine learning, but still turned out quite accurate. So what would be a good sample size if we want to do machine learning, identify disease mechanisms in patients with delirium? There are some studies around that say if you want to do rule of thumb would be 10 to 100 samples per EEG feature. We had 300 features in these patients. We don't necessarily need all of them. But let's say we had a EEG study with 90 features, 10 samples per feature, we would require 900 samples. It means 900 patients. And this is where dry EEG comes in. It's obviously you can't do 900 CSF exams in patients, and you can't do 900 fMRI scans in patients, but you could do 900 EEGs. But then again, also these need time. And if you see, you have to the left, you have the dry, you have the gel-based EEG. On the right, you have the dry EEG. And what really is the difference is time. Like when you do dry EEG, it's 20 minutes per EEG. If you do gel-based, it would be 40 minutes. So you can do your study in 300 hours or in 600 hours. So you can do twice the amount of patients just by using dry EEG. And what matters in machine learning is really the amount of data you have. And so what we did is we looked at common features you would investigate in patients with disorders of consciousness, and used the ANT system and used wet EEG and dry EEG. These are the montages of the high density EEGs. And we compared that in 33 individuals. We first looked at the event-related potentials. That in this case, the MMN, mismatch negativity, which is a event-related potential related to attention in a subject. And we see that dry EEG and wet EEG really are equivalent. So you can do that with both. So you don't lose any information using dry EEG in MMN studies. And then we looked at phase lag index, which is a measure of connectivity. MST diameter, which is minimum spanning tree diameter, is another measure of EEG-based connectivity. And these are Blunt-Altman plots. And what you see is basically that all the dots are somewhere in the confidence interval. So also looking at connectivity measures, gel-based EEG and dry EEG are somewhat equivalent. So we can do EEG research using dry EEG. It's really an accurate tool and provides the same information we have from gel-based EEG studies in less amount of time. And this is also a study where we use dry EEG in stroke patients, and we saw that another type of connectivity measures, which is the amplitude envelope coupling, is related to STRAM2, TGF-beta, so markers of microglia activity and inflammatory activity, systemic inflammation. So it also catches some sort of pathological substrate or precipitating biomarker or systemic inflammation, and is related to that. So this is the last slide. It's a very quick introduction to the topic, and I find it really fascinating to work on QEEG, which certainly provides features related to delirium that cannot be seen in qualitative EEG, and that may also be missed when just looking at a phenotype. AI approaches are really the way to go, I think, but you require vast amounts of data, and this is certainly a strength of dry EEG, is that you can obtain the same results as using a gel-based EEG in a short amount of time and gather lots of data from many patients. So the kind of can acknowledge the clinical heterogeneity and variance, and are more likely to find mechanisms associated with delirium that will help us advance our understanding and clinical management. So thank you for your attention, and looking forward to your questions.